science to our own methodologies, we will get far more bear far more fruit than what we normally would do. So thank you very much. And without any further ado, I request Professor Rakesh to proceed with the session. Thank you very much to Dr. Suraj for organizing the session for all of us. And we really look forward for the time that ahead of us this afternoon. Over to you, Professor Rakesh.
Thanks, Professor John, and everyone who have taken the time out to be here with us. And without further ado, I'll just proceed to the hands-on approach, and then hopefully we'll be able to learn from the Socratic questioning, which may ensue if we have shown you something stimulating enough. So I'll straight away go to our first patient, who will be, an illustration to us in diagnostic and therapeutic reasoning to begin with, and that we think is one way of reasoning which we are trying to highlight as the system 2 approach, according to what psychologists call as the dual processing theory. So in system 2, we do the reasoning, we do the thinking, we do the analysis, whereas in system 1, there is much less of that, and it's more of pattern recognition. So when we see patterns, we are very fast at that point of time. So we just match patterns and we say, okay, this is the thing. And then we make a decision on the basis of that. So today I'm trying to show you all that, both system 2 as well as system 1. I think we'll start with the system 2 and move to a few system 1 decision making, and then finally another system 2, where we'll probably try to wrap up everything and hopefully get your questions either in between or even at the end. And I'm looking forward to it. So let's start. So yeah, so we have our residents here, we have our students here, and Dr. Pawan is holding the camera, and he has been trained not to pick up any identifiers of any patients to preserve their confidentiality and privacy. Most of these patients we have taken consent, because we have a system of taking consent even before we admit them, and we'll talk about that later. So let's go to this young man who is sitting in front of us, and I've told him that we are live with a few doctors from across the Arabian Sea, so he's also looking forward to it, and he's hoping to get some pointers from you all. And he has been ill since the last 3 months. So this is Dr. Supriya, who has made those illness scripts that we have already shared. Dr. Rajkumar has shared those illness scripts. He is also here. He's a psychologist, and because we are interested in this field of medical cognition, that is diagnostic and therapeutic reasoning, a psychologist, because it's ultimately about psychology, the psychology of the mind, and how we think, how doctors think, how patients think, and how to make our students think better. So Dr. Supriya has already shared the illness script of this patient which he has gathered, and we have shared it across in that group. I'm not sure if all of you are there, but I'll give you a small sequence of events which he had, because ultimately we are just giving a demo of how to move from symptoms to diagnosis. The symptoms with which he started was, he's an auto driver by profession. I'm not sure if there are autos there, but in India the auto is kind of a vehicle which is a three-wheeler, very often used, and if you're sitting on it, it doesn't have much of a spring action, so it's a very bumpy ride. And he has been noticing in the last 3 months, 3 to, he told me it's 8 months, but anyway, so he's been noticing. Yeah, so what he told me was, yesterday I was also taking his history in his language. Now, language is very different because he has come from 2000 kilometers. The next patient I will show you is from 20 kilometers. So the language in India varies from every 500 to 1000 kilometers. So he has a completely different language. So I asked him in his language, and he said that he was feeling this, when he is driving the auto and he is driving for a long time, after 2-3 hours, he He feels as if he's got an extreme heaviness of the leg. He is not able to move his legs. They feel very heavy, as if somebody has put some weight around those legs. And he also feels kind of numb in those areas, and he has this kind of tingling sensation. So this is the exact thing, description, the script which he shared with us, and, uh, and and we did not know what to make of it. And to tell you the truth, when he came to us for the first time, this 2-3 days back, we did a system one. We just quickly saw him, and we asked him what is the problem. Maybe we were in a hurry or something, and we then proceeded to do an examination. So perhaps we will also proceed with the examination and tell you what we found. But even before that, the person who brought him here, our patient advocate, he said that they had already got an MRI done and that was normal. So that again biased us to think that maybe we were dealing with something else. And when I saw his gait, I thought he was, lifting up his legs as if there's a steppage kind of a gait. We also call it an equine gait, like a gait, as if gait of a horse which is just moving slowly. So that's what I thought. But now I don't know what you will make of it. So appealing to heart. So be careful with the identifier. Yeah. Yeah. So Pawan is just showing you the legs so that you can appreciate how he is walking. Now, although on that day I felt he was lifting his legs like a horse, later on when I examined him, after examining him yesterday, I don't know, I don't feel that that is the same thing. I will show you now. Biswas is showing you. Can somebody go along with it so that it doesn't go on? So our resident of Ravi is walking with him. You can see his legs. He is walking carefully because what you might notice is that he is walking very carefully, and that may indicate nothing else. That may indicate that he doesn't have a lot of balance. But and do you notice that he's dragging his feet a bit? Well, maybe it's not very noticeable. Only thing I can make out is that he's walking carefully. Now, if somebody is walking carefully and he doesn't have balance, can I make him walk on a tight rope? So I'll ask him to walk on a tandem. That is, ask him to walk on a straight line here. So Pawan, please do, and Ravi, you be ready to catch him if you call. Yeah. So, he's straight line down. So yeah, you can show them the hands also how. Yeah, he's able to manage it. And he's got a little bit of swaying, that's all. A little bit of swaying and a little bit of thing. Which is slightly, slightly less than normal, I would think now. Of course, I have become biased by my examinations, but when I saw him the first time, to tell you the truth, I thought he had an equine gait. I don't any longer think so. That's a shield. Now, Dr. Chandana, would you like to show us the examination findings of the spinal cord? So, essentially, we want to see where is the localization. So now we come to the diagnostic reasoning part, which is, what we teach our students right from their final MBBS days. That is how to localize any problem, any illness has to have an anatomical localization. So now from his history and a psychosocial perspective, we are moving into the body proper, where we are trying to localize the pathology. So does he have a pathology which is giving rise to his symptoms? So generally for most of us in the field of biology, it would end here. I mean, we would be satisfied with the data points that we collect about the pathology, and we would basically try to tackle that pathology. But as we go deeper into medical science and cognitive science and this field of medical cognition, we realize that there are many more data points to be collected which can help us to do better for the patient. So we will show you how to collect the body data points. So Dr. Chandana is going to illustrate. She will straight away jump to by showing us the motor system examination. We are telling you that the higher mental function is normal in his neurological examination. The cranial nerves are normal, and his neck doesn't seem to have a problem. His spine from whatever we have examined doesn't seem to have a problem. And so straight away to the motor system. So we can start with the power and then the reflexes. Do it quickly so that we can show them more patience. Yeah.
ऐसा करो.
হ্যাঁ ওটা আপনার দিকে টানুন হ্যাঁ হাতটা আপনার দিকে টানুন yeah so he is trying to pull and the other hand upper limb huh. So Chandana, what do you think about his power in the upper limbs? Achha, do it in the lower limbs, show the lower limbs. Yeah, show the lower limbs. And you can just put your hand on the knee joint, yeah, and let him flex it. It is clear that you put it and try to see. Ever tulun, pada tulun. Either nowadays, bhaaj kore othate pareন. হ্যাঁ, bhaaj kore. Yeah. So for a young man, I think this is less. Okay. Then again. Yeah, this is slightly lesser. And going by the symptoms, he had more problems in his left lower leg. So I would say this is 4 minus or 4 plus power. Okay, the 5 is great, 5 is normal, and 4 minus 4 plus is less than that. 3 would be that he is able to move against gravity, but it is much less than normal. So this is just less than normal and not much less than normal, which is why you see he's almost normal. I mean, if you had seen him in some other place, you wouldn't have been able to make out that he may be having a neurological problem, or he may even have these neurological symptoms. But he's come all the way 2,000 kilometers for a solution. So he must be having a problem, although his MRI is normal. So now we'll come to why his MRI was normal, but before that, let Chandana demonstrate the reflexes. Yeah, so we start with the upper limb reflexes. So, yeah, focus on the biceps. Yeah, so as you can see, there is no contraction of the biceps. Go ahead to the next. Now here you can see there is no contraction of the triceps either, or maybe a very vague one. Okay, so go with the brachioradialis here. So there is no contraction here also. Chandra, can you do that? Yeah. So the biceps are absent, the triceps again. Yeah, triceps you just need to pull it here like this. And okay. Here it is. So even this tricep is not there. And let it be here. And this is the brachioradialis. Even this is not working. So none of the reflexes here are working. So all these signals that we are sending to the spinal cord, they are getting blocked either in the afferent pathway while going to the spinal cord or while coming back from the spinal cord. So either way they are blocked. So we don't know where the block is. Is it at this nerve level or is it at the spinal cord level? Be careful about the identifying. So we don't know where the block is. Now let us go down to the lower limbs. Okay, so yeah. So here you see the knee. And let's see the knee. So as you can see, the knee is jumping as opposed to the biceps and triceps and brachioradialis, which are not at all reflex. I mean, they were absent. But here it's jumping. The ankle is jumping. One could even call this normal, but it's probably exaggerated. Now here, so you can see a little bit of subjectivity, but we are convinced because of the overall picture that these are exaggerated reflexes. Now here you see this is also jumping. Now let us look at his planters. So this is the toe. Now in plantar extensor this will become like this. In a plantar flexor this will become like this. Normally it should become like this. So let's see what happens here. So as you can see it is becoming extensor. And in this side also it's extensor. So bilateral plantar extensor, hyperreflexia, absence of reflex there, what would we think? Now this is the crux of the diagnostic reasoning where one would require a knowledge of anatomy, only knowledge of anatomy, nothing else, just anatomy. One needs to know the spinal cord, the anatomy of the spinal cord as well as the brain, the cortex and the peripheral nerves. So essentially there are pyramidal tracts coming down and there are inhibitory interneurons So what has happened in what we can make out from this clinical picture is that the current is absent in the upper limbs totally. So we can hide, but it is all present in the lower limbs. The current is present. So we can say that either the nerve, the wire here has gone, or there is a problem in the spinal cord here, especially that segment of the spinal cord which supplies this, the biceps, the brachioradialis and the triceps, which is C5, C6 and C7. So these segments of the spinal cord are damaged, and that is the reason we don't have any current here. And because these are damaged, that is the reason we have the lower limb showing hyperreflexia as well as plantar extensor, which is a very, very classical feature of what we teach our first year students in physiology, upper motor neuron lesion. So the upper motor neuron starts from the cortex as pyramidal cells of beds, and then it goes down to the um, spinal cord and anterior horn cells, and after that it comes out as lower motor neuron. So here we think it is an upper motor neuron problem, which is affecting the lower motor neurons also, which are coming out of the spinal cord, and that is the reason you are seeing a partially lower motor neuron type of lesion in the upper limb, but upper motor neuron type of lesion in the lower limb. So so this is what we are thinking. So the entire thing, from when I saw him 3-4 days back when he came the first time, I thought he had a equine gait, a foot drop, and then I changed. Once I immediately did this quick cursory examination, I changed my diagnosis to a spinal cord problem, and that too at the level of the cervical region. Now that thing about the MRI, why his MRI was normal, we found out because they had done it wrongly. They had not done the MRI in the cervical region. They had done it in the thoracic or probably even lower down, because he was complaining only of a left lower limb weakness along with bilateral limb heaviness. So they thought it must be a lumbar problem, and they did the MRI there. So here you see how a little bit of clinical objective finding and diagnostic reasoning, which is very basic. I tell you, whatever I showed you was basically MBBS uh, anatomy physiology knowledge. This kind of basic thing allowed us to get a different viewpoint of where we should do the testing. So here we changed the entire diagnostic reasoning, and we switched from the lumbar region to the cervical region. And we can show you the MRI of the cervical region. I think they're showing it to you from another desktop which is there in the ICU. And is it shared in your screen? You can see how it looks like. Let me also have a look. Yeah, it's just okay. I'll just take a look. Yeah. Okay, so you can see it here. In this C5-C6 region, I don't know whether you can see my finger. But yeah, so you can see a compression by an intervertebral disc. I think the previous one was better. The previous picture. The previous picture. The first one. Not these. This one. So you can see an intervertebral disc which is a black, a relatively darker. Yeah, can you make it bigger? A relatively darker thing. Yeah, and do we have any cursor to show them? Because I am pointing my fingers, but I don't know whether anybody is seeing that. Huh? Yeah, Charan, can you show them this black area? Yeah, exactly. Which is compressing the spinal cord. And this is at the level of, exactly at the level of C5, C6, C7, which we could clinically find. So you see, there is a very strong correlation between our clinical diagnostic reasoning and the visual MRI findings. Very, very strong. So this is pathology. This is the body and the biology which is generally mostly thought to be part of diagnostic reasoning. And this is a very simple thing. There's nothing much to it. And already now we are moving into the therapeutic reasoning. So what should we do? Initially the patient was scared that should we operate, and he is currently moving around. He's almost normal, as you can see. So should we operate on a normal person relatively, and then what if he becomes more paralyzed? You know, nobody will be able to forgive. We won't be able to forgive ourselves. The patient won't be able to forgive himself for that decision. So here is a very, very crucial decision. Should we go ahead and operate or not? The surgeon feels yes, we should. Because he has definitely got a reason that he says that if he doesn't tackle it now, it may become more difficult. And of course, we know that as time goes, the compression may cause further problems in the neurons, in the functionality of the neurons. So, I mean, he's right, of course. And so, what do we do? I mean, how do we make a decision? Do we leave it to the patient? Like, there's currently a shared decision making movement, and we need to be able to share all our uncertainties with the patient and allow him to take an informed decision, which means the onus shifts to the patient. But although we'll still be supporting him with whatever information and guidance that we are capable of, but then, in the developed world, it's very difficult for a patient to be able to, you know, bring out that much of capacity to handle this kind of uncertainty. So most of the times, I don't know, maybe even in the developed world, patients would rely on the decision the doctor takes for them. So if the doctor says, okay, let's do it, they will also more or less try to arrange all the resources. It's not going to be very, I mean, it's not very expensive here in our institute, but it's not completely free either. So there are a lot of resource constraints which need to be tackled, and the most important thing is the outcome. So what could be the outcome? I have shared a PDF of clinical tips and diagnostic reasoning with Dr. Siraj, and maybe I'll share it again in the WhatsApp group if all of you are there, if you've not gone through that already. And they talk about Bayesian analysis here, which means that you think of the priors. What is the prior knowledge in this area as to what happens to people when we operate in this particular situation? Let us say a young man who is relatively well preserved functionally, and you operate on 100 such people. What are the outcomes? So if you already know of that, isn't it simple to say that yes, if 90 out of 100 had a good outcome and the rest 10 did not have that much of a bad outcome, I mean, they didn't get completely paralyzed, then one can have reasonable confidence to say that yes, why not go ahead with it. But on the other hand, if some people say or find that 50 people had worse motor deficit than what was earlier, then of course we wouldn't like to do that. So the only hitch, of course, there is a lot of good data available, but there is a lot of data which is not available. Like every day, there's tons of data that is getting wasted. So many such scenarios who are not getting recorded and not getting shared. So what we need to do is build up such a database, and that is, I think, one of the reasons that we are sharing all this with you here, is that we want each and every such illness script and each and every such clinical encounters to be documented, so that persons who are also having the same problem can access those and make a much more better informed decision, rather than just go by what is currently available as numbers and mean values. So anyway, so I think we have done a little bit of system 2 thinking here. Now we'll quickly move on to a few system 1 cases where we'll also talk about the anatomical approach and biologic diagnosis. In the meantime, would any one of you have any questions about this patient or any comments? Maybe some of our team members might want to make a comment, particularly from the cognitive side. So no one. Shall we move to the next patient? Dr. Rajkumar, would you like to talk something about the psychosocial aspects of this patient? Because you see, again, we have to deal with a lot of data points. It's not, what we showed you was very simple biologic understanding of the body. But there is so many more data points which are psychosocial, which would be very important to gauge the the level of decision that needs to be made. So we haven't addressed that, and probably we are taking a shortcut there. So there's a lot to think about here, and a lot to spend time with the patient around this. So if Dr. Rajkumar is not giving us any, Supriya, you have any inputs on this? Yeah, would you like to?
His father that affected him in his life aspects.
Yeah.
At early age, in 12 years of age, he lost his father. That turned his life into ups and downs.
Yeah.
Like he discontinued his study at 8th class,
Right.
and continued as a daily wage laborer in construction.
Right. So
sector.
loss of father in early childhood, child labor because of that.
Because
Good,
of that.
good points.
And
Yeah.
he also lost his mother at the age of 15 years.
Again-
That made him alone.
Again, losing
Again.
both parents at a time when most people would consider it as a child. Yeah, losing both parents at 15 years, child labor. So these are very, very important, aspects to his entire condition. Yeah. What else?
And if they have small disputes in the families regarding land and all,
Yeah.
About financial issues.
Yeah.
And that's it. And his first child was the expired, sir.
Yeah.
At the age of 1 year.
Hmm.
They stayed up till 3 months in the hospital, but they couldn't save him. But after spending 80,000 rupees also.
Yeah.
That may be acted as trauma on his mental health.
Yeah. So there's a lot of pain points in this patient, which is suggesting that there is a lot of possibility of psychological issues. But and what we are seeing biologically is a gross MRI finding with some very good biologic data showing us that there is a loss of reflexes, there is a plantar extensor. So we cannot throw away any of these. So is it, I mean, we cannot even correlate how these psychosocial issues are correlating with this prolapsed intervertebral disc. In fact, why did he have the prolapsed intervertebral disc? And at what point of time did he have this? He has had symptoms in the last 3 to 6 months. But when did he actually develop it and why did he develop it? What were the reasons for developing a prolapsed intervertebral disc? That was the cervical region. He had a history of trauma maybe 10 years back, isn't it? And but 10 years back, and why is he having a prolapsed disc now? I mean, we know in the classical history of prolapsed disc, it is the patient is lifting a heavy weight, and suddenly the patient has a sensation of giving away and sensation of pain, followed by neurological deficit. He never had that. At least he never complained of that kind of sudden onset. So why he and how he developed this intervertebral disc is also a mystery for now. So although we've got an anatomic diagnosis, we still don't have the etiologic diagnosis. We just know that there is a prolapsed intervertebral disc. But why did it prolapse is still not clear, isn't it? So now let's go to a quick few system 1 reasonings, and we'll again come back to another system 2. So here is one of our patients.